Good morning, my name is Dr. Sarah Richardson and I'm presenting on disease burden in Ugandan emergency care. Emergency care is a specialty which is considered to be in its infancy in Uganda, but in reality emergency care is being provided to and utilised by Ugandan patients regardless of whether the system is capable of producing optimal outcomes or not. For policymakers to make informed decisions, adapt and develop the system according to patient need, there must first be an understanding of the actual utilisation of emergency care services in the country. A critical component of this is to understand the disease burden at emergency facilities and compare and contrast quality indicators related to specific conditions. To address the issues of current cumbersome disease classification models that are extremely difficult to implement in low-middle income countries and emergency care settings, our study designed a novel system to simplify disease coding and create a practical and pragmatic approach to allow for meaningful data collection in emergency care. Our system codes diseases according to emergency care resource allocation. Similar conditions are classified together as they require similar treatments in the emergency care setting and have a similar anticipated spectrum of disposition, morbidity and outcomes. We performed a multi-centre study which took place across 11 government facilities in Uganda, collecting and collating, analysing 4,704 patient records. When we addressed the results, as expected, non-infective and infective origin classifications were similar in burden, with 25.7% of the disease classification being injury-related. As found in other studies in the region, malaria was the top diagnosis. Head injury featured in the top 5 in Uganda, unlike other studies in the East African region, and this is likely to be due to the motorbike riding culture in the context. Interestingly, we found almost 35% of patients had 2 or more diagnoses listed in their record. This demonstrates the need to not solely focus on the primary diagnosis. Our patients are often complex, and it's vital we understand the true total disease burden in our patient population. Analysing acuity was a challenge, with almost no documentation of triage category and less than half of patients having any form of vital signs documented. Almost 3/4 had some form of IV treatment, and concerningly, over 50% of patients received an IV antibiotic, despite only 30% of patients having diagnosis of infective origins. Emergency care is indeed being provided every day, despite the infrastructure and required resources reportedly not being in place at facilities. Our novel coding system needs to be further validated, as it has the potential to form a pragmatic and practical approach to disease classification according to resource need. This would ultimately allow policymakers to make informed decisions regarding resource allocation, infrastructural development and emergency care system design both in Uganda and the wider sub-Saharan region. Thank you.